Welcome to the afternoon plenary for the 39th Annual Conference of NAMI Maryland. My name is Kate Fahrenholt. I'm the Executive Director of NAMI Maryland. Before I hand this over to this amazing panel that we have, I just wanted to say a little word about this year's conference. And we have brought back our very, very robust annual conference. As a matter of fact, we've expanded it. And as you all have noticed, there have been a few technical difficulties. The platform that we're using has been working to correct them, and I just want to apologize for them and thank you for your forbearance. But we are going to be able to provide recordings for everything, for anything that you might have missed. That said, I just want to hand over the mic to Morris Cyphers to moderate this wonderful panel. Thank you.
Thank you so much, Kate, and to everyone in the session for joining us today. I'm Morris Cyphers, the Policy and Advocacy Consultant for NAMI Maryland. Starting us off will be Dr. Aliya Jones, the Deputy Secretary for the Maryland Behavioral Health Administration. And joining her are an incredible leadership team from BHA, Stephanie Slowly, Dr. Maria Rodowski-Stanco, and Kathleen Rebbert-Franklin. Today, they'll be discussing the future of behavioral health crisis services in Maryland. And like Kate mentioned, this is an incredible group of presenters. We're grateful they made the time to present this plenary today, and NAMI is providing plenty of additional information, including some in-depth bios in the conference program on the official conference website. And before I turn it over to Deputy Secretary Dr. Jones, just a few brief housekeeping items. If you've got questions, please post them on the social wall to the right hand of your screen. If there's time, we will address questions at the end of the presentation. There's a little bit of a delay between posting and when they get into our queue, so keep that in mind and post when it comes to you. The social wall is also the place for comments, concerns, or technical issues. We will try to address as appropriate, and for tech issues, someone will reach out as soon as possible. And finally, when this workshop closes, you'll be prompted to fill out a brief survey. As a reminder, if you would like to receive CEUs for this workshop, you must complete the survey in order to qualify. So again, a very big welcome and an even bigger thank you to the Deputy Secretary for Behavioral Health, Dr. Aliya Jones. You can take it from here.
Dr. Jones, you're muted.
Thank you. Good afternoon. My name is Dr. Aliya Jones. I'm the Deputy Secretary for Maryland's Behavioral Health Administration, and I'm definitely glad to be with you all on today. Next slide, please. Glad to be with you all and with my wonderful, or at least a portion of my wonderful team, to talk with you about crisis services in the state of Maryland and other topics as well, child and adolescent issues and the transition to 988. Certainly, the Behavioral Health Administration is focused on issues that confront Marylanders of all ages that pertains to behavioral health and wellness. And without question, with all the challenges that we have been going through with COVID, behavioral health is front and center of everyone's mind. And it's certainly front and center of our minds in terms of how do we help the state and each individual confront the emotional challenges on top of all of the other challenges that people are dealing with during this time. Next slide, please. So we focus on ensuring equitable access and outcomes to services, making sure that we're using data to drive our decision-making and integrating our services across various disciplines. And there is no place where that is more critical and relevant than in the development, the management, and the oversight of crisis services and in the supports that are provided through call lines, and then also making sure that we are addressing emerging and active issues in our youth populations. Next slide, please. One of the questions that people always want to know about is how are we doing in the state with regards to suicides, because they're hearing stories in other places that suicide rates are going up, and that certainly is something that we were very focused on from the onset of the pandemic, was with the expectation that suicide rates were going to go up because the conditions were certainly ripe for it. However, I'm very glad to be able to say that suicides in the state of Maryland have not increased above historic levels, which is, so you can let all your friends know that that's not what's happening in Maryland. That's important for people to understand. However, what we are seeing is we are certainly seeing that the stress that people have been under during the pandemic is manifesting itself or showing itself by an increase in the number of behavioral health and emotional crises that are presenting to our emergency departments, and namely those who are going to the emergency departments after having made suicide attempts or having suicidal thoughts. If you look at the January to June numbers of presentations to the emergency department in 2019, we had 9,200 individuals go to the emergency department for suicide attempts or suicidal thoughts. That number was down very significantly in 2020 because nobody was going to the emergency room, or people were trying to avoid the hospitals, and we wanted people to avoid the hospitals as much as possible unless they were in a crisis state. But then you look at what's happened from 2021 from January to June. With the data that we have ending at the beginning of September, the number of people who have returned to the emergency department has rebounded in excess of historical trends. And so certainly, though we aren't seeing completed suicides, we certainly are seeing lots of signs of increased emotional distress presenting to our emergency departments. Next slide, please. And this growth is going across all age groups. If you look in the fourth column, that shows you calendar year 2020 to 2021. And then you look in the first column, which shows all of our age groups. In every age group, we're seeing increases in the utilization of the emergency department for suicidal crises. And the greatest trends are in our youngest populations, 0 to 17, and then also in our 65 plus populations. Next slide, please. And so we are dealing with the COVID pandemic in the midst of what we know was the opioid epidemic, which predated COVID, and where we have not seen loss of life due to suicide, we certainly have seen increases in loss of life due to opioid overdoses. And we look at the numbers in 2020. Compared to 2021 for the first quarter trends, unfortunately, we had a banner year with regards to the number of people who lost their lives due to an opioid overdose in the first 3 months of 2021. So we are dealing with multiple crises within crises. And therefore, obviously, hyper-focused on how do we meet the burgeoning and continued needs across the state of Maryland. Next slide, please. The department has been committed to building a robust crisis services system, which predates COVID, goes on for many years. However, I would say over the past 4 years or so, there have been a lot more resources, financial resources that have been poured into ensuring that people had access to crisis services as needed. And I just wanted you to see the commitment, the financial commitment of the Maryland Department of Health and our federal partners to addressing crisis services. And I have no doubt as the years go by that these numbers will continue to grow as we continue to try to stabilize our society from the impact and the fallout from COVID-19, and then also the recognition of all the underlying issues that we were facing prior to COVID with regards to disparate health outcomes. Next slide, please. And so I'm glad to share with you all, or to share my team with you all today. It is share my team with you all today who's here to give you lots of great information about how it is that we are growing and developing and responding to what's happening on the ground. We have our Maryland Crisis Response System work that is going to be presented by Ms. Stephanie Slowly, who is quite adeptly leading that work for the department. I'm looking forward to having you hear from her. She will be followed by Dr. Maria Rodowski-Stanco, who is the lead for crisis services for children, adolescent, and young adults for Maryland's Behavioral Health Administration, to talk to you about all the wonderful work that she and her team are doing to develop, to enhance our ability to respond most appropriately to crises in child populations, which really do need to be managed differently than how we have managed crises in adult populations. So excited that you're going to hear from her. And lastly, and certainly not least, I'm here from Kathleen Rebbert-Franklin, who is our Director of Service Access and Practice Innovation, who has overseen the 211 Press One initiatives for the state of Maryland since their inception, who's going to be able to provide you an update on the transition to 988, what that means, what that might look like for the state of Maryland. And so with that, I have to jump off the presentation, but I'm leaving you in very, very capable hands. And I'm thankful to my team for being here. And I'm thankful to all of you for coming and hearing about all the wonderful work that we're doing. So please don't hold back on your questions. If you have questions, this is the right group to ask them to. Have a wonderful day and a wonderful conference.
Thank you, Dr. Jones, and thank you for your welcoming and opening. I'm very thankful to be a part of this presentation today, and very thankful to be able to talk to you about the many robust efforts that the department is undergoing around crisis response system. Although I am honored and pleased to be here to talk to you about it, I am only the voice of a very robust team that includes both Dr. Rodowski-Stanco, Kathleen Rebbert-Franklin, and a host others within the department and our partners that I'll talk to you about the work that we're doing in this space. Next slide, please. So the Maryland Crisis Systems Work Group has a vision that our statewide public and private integrated behavioral health crisis system will be a system where all Maryland residents will receive 24/7 behavioral health, which is mental health and addiction, access to Hotline, crisis walk-in, mobile crisis teams, stabilization services that provides the most effective, least restrictive, consumer and family-focused approach to how we deal with crisis. And we look at it as a continuum from the beginning of being onset of trauma all the way to wellness and recovery and every part in between. So that is how we're looking at it comprehensively at the state, and that's what we're driving towards. Next slide, please. So we have developed this work group. We started to meet internally as a department back in the summer of 2020 and the height of the pandemic. We all decided that there, as Dr. Jones indicated, there's a lot of investment at the federal and the state level across the department and with our sister agencies, really looking at crisis. But we felt led, because we are the behavioral health authority of the state, to really drive for best practices, standardization, and how we really enhance the quality of services rendered, that we didn't allow the money to drive how we render services, that we would establish our own best practices for that. So we developed this Maryland Crisis Crisis Work Group, and our work group has several subcommittees that we are actively working in. And so these subcommittees are led by experts in the field, a lot of our BHA leadership, and with a host of stakeholders that are also engaged in the work that we're doing. So our Standardization and Best Practices subcommittee is chaired by Darren McGregor and Sharon Lipford, who are within our administration. And this group is charged to look at the systemization of definitions for crisis, looking at how we can develop standards and also regulations. And they've been really focused on a recent bill of HB 332, and really how do we integrate comprehensive services like CCBHCs. And I know there's a lot of conversation in the space around this. And so we're all looking to see what is the national best practices saying, what do we think from a state is going to be the best way for us to render these services, and how can we integrate all the knowledge that we have and really create a system that's responsive to the needs of the state. We look at that from a data-driven perspective. So we have a data dashboard and system mapping subcommittee This is led by Dr. James Joe and Susan Bradley of our administration. And this team is charged to identify elements in partnership to develop a database that is a statewide dashboard. And this is really important to us. We feel as a department, it's important that we are data-driven in our responses and data-driven in how we really move the needle forward. And it also allows us to know what gaps are out there. Most notably, we're looking at HB 1121, which has asked the department to embark on a bed registry and referral system. And so we are really actively working on this as a whole department. And our Secretary Schroeder has been keenly focused on this and ensuring that we are wrapping our arms around the behavioral health community and ushering individuals to the appropriate settings that, as I stated earlier, are least restrictive and most appropriate. We have our child and adolescent and young adult, which is chaired by Dr. Maria Rodowski-Stanco. And of course, you'll hear from her and she can explain her area best more than anyone else. But she has been charged to really look at the triage, acute intervention, stabilization, and referrals. She's doing universal screenings around trauma, pediatric consultation models. She's looked at ACEs. She's looked at other referral options. And she really has what I believe is going to set our state apart and nationally have us stand out, because we're not looking at crises from the adult space, but we're really carving out how we can be responsive and appropriate to children and young adults. And so I just cannot wait for you all to hear from her as soon as I get out of her way. We also have the 988 integration, which Kathleen Rebbert-Franklin will be talking about. As you all know, the federal government has come down with the mandate for all states to move to a 988 number for crisis, for suicide prevention. And so she has been charged to work with our partners at the department to look at the financing, capacity building, and coordinating of those responses with our current 211 Press One efforts. And she'll be able to really give you the inside details of what she's been doing thus far. And she is the guru in this space. So I learned so much from her as well. Next slide, please. So ultimately, what we feel is most important is that our practice principles have to be a full spectrum of crisis services, where we're looking at it from an innovative and transformative perspective. And we feel that what's going to stand our crisis system apart is that we make sure that we're focusing on a couple of key elements. We want to make sure it's recovery oriented, that it has significant roles for peers as they help usher individuals through the crisis continuum of care, that we ensure that it's equitable and culturally appropriate, understanding that everyone experiences trauma and crises in different ways, and how we respond to them needs to be patient-centered and focused in order to be responsive to that. As Dr. Jones indicated earlier, we want to make sure we have safer suicide approaches. We want to ensure that we have safety and security for staff and people who are in crisis. And of course, our community partnerships are critical and key, that they are really integrated, that we all are working in the same fashion and driving towards ensuring that anyone who's experiencing crisis within our state and even in our local borders are being able to find the resources they need in real time. Next slide. So we're looking at this in a couple of ways. We look at this in a way of access and immediacy, coordination and partnership, and information and education. From the access and immediacy perspective, we are thinking about this from, do we need to have a hybrid fashion of where we're going to be rendering services both in every jurisdiction and some that may be regionalized depending on what the makeup and composition of the services are and what the community needs. So we're thinking about, how do we ensure that we have 24/7 crisis call center hubs for individuals who may need those? We need to make sure we have enough mobile crisis services teams in the state to be responsive. We want to have safe stations, walk-in and urgent clinics, and stabilization centers that can support and wrap around those services when people are in immediate need. And of course, we also know that some individuals may need respite or somewhere to stay. So crisis residential services is also a key component of our crisis system. From a coordination and partnership perspective, again, like I stated earlier, we really want to focus on the importance of peers and how peers can really be utilized and anchor us in ensuring that people are navigating very seamlessly through our continuum of care of crisis, and ensuring that they're not being lost in the system at any point. We also want to make sure that we have a standardization of operational fees, recognizing that currently the majority of our resources for crisis are being grant funded. And so we're really looking at the sustainability components of how we stand up and keep our system operational regardless of the payer source. And that would not just be in the public behavioral health space, but also looking at private insurances and people who are underinsured or uninsured. We're also looking from data perspectives for tracking and outcomes. And then we're looking at our law enforcement partnerships, so CITs, and really ensuring that we're having a arm-in-arm partnership to make sure that people are not just being justice informed, but being patient informed or being clinically informed if they're in need of crisis and they're getting to the right place. And then with information and education, we want to make sure that public and provider education awareness is as primary, optimally given and out there, that we're providing as much public health information as possible and educating providers on the right ways and systems to really place people and notice them at the onset of crisis or trauma so that they don't have to fall deeper into a crisis episode or space. Next slide. So I've spoken earlier about who our state partners are and who we've been working with, and this doesn't even encompass everyone that we're working with, but these are the major tenets of what we've been doing thus far. So our big partners are really just, BHA has been leading the charge, and we really are thankful and appreciative to all of our stakeholders who volunteer their time, effort, and energy to help us in the Maryland Crisis System Work Group. We also work in key partnership with the Governor's Office of Opioid Command Center, and we really are just thankful to have them as thought leaders and partners in this work. And then, of course, we also do this in strong partnership with our colleagues in our Maryland Medicaid, who really help us look at the sustainability aspects of the services and how we can ensure that in our public behavioral health space, we're moving forward to do as many services as we can right now to provide crisis services in a more sustainable fashion. And we've already talked about the different subcommittees that we do, whether it's best practices or the data dashboard, financial stability, the work that Kaya is doing and the work of 988. But we also have a statewide partner with the Health Services Commission Review. And they are really being change leaders and have funded some regional catalyst grants where they've been doing some piloting work, and we are really arm in arm with their grantees and really looking at how we can learn from their best practices and their lessons learned as we're developing this crisis space. And their grantees are GBRICS, which is in the greater Baltimore region, and TLC, which is really down in the suburban area of Prince George's County, and Tribe, which is on the Eastern Shore. And we're also working with our own current funds to do another regional partnership in another area that will be done. And those fundings and that request for proposals is forthcoming. Next slide. So some next steps that we have is just to create an opportunity for alignment across the school system and MSDE, and this work will be talked about a lot with Dr. Stanco. We also strive for alignment with the HSCRC grant holders and really looking at our broader efforts to really ensure that we all are walking in strong alignment as we're moving forward in this crisis work. We want to continue the discussion of shared investment to build out a robust system of care, utilizing economies of scale. So really working with those thought leaders in the fiscal areas to figure out how we can only be responsive in the public behavioral health space, but as a state as a whole. And then exploration and alignment with the opportunities to enhance the federal match that is coming down. And if you are aware, and within the recent funding that we've seen in the current administration, they've allowed some federal matches around mobile crisis, and we're trying to see how we can maximize those opportunities, but then leverage those things. And we actually were recently awarded a CMS planning grant to really help us work through some of those great funding details, and how do we really plan out the system to really be able to be comprehensively responsive. And so I'm really excited to come back, hopefully next year, to tell you about all the great things and where we've landed. Next slide. So that is it for me. Again, I'm happy to be here and answer any questions at the end, but I'm more excited to turn this over to my colleague, Dr. Maria Rodowski-Stanco, who's going to really talk about her vision around how we're going to be addressing crisis services and child and adolescent services as a whole. So Dr. Stanco, I'll turn it over to you.
Sure, and thank you. I'm happy to sort of pick up and continue on this. As you know, I've been sort of very invested into this from, the time I came on at BHA and want to see this come to fruition where we really can have a universal system that's meeting the needs of, our youth and families, but also other, specialized populations that need a slightly different approach than a one-size-fits-all model for our crisis services. So next step. Next slide, please. Oh, back up one. So wanted to particularly talk about a couple of opportunities that we reached out for. So early on after COVID, there was money being pushed out in terms of emergency grants to address the mental health and substance use needs during COVID. So we applied for that and then ultimately received $4.8 million towards that, and have targeted that money towards setting up what makes sense for child crisis stabilization services, utilizing the same regional approach to be able to provide some sort of statewide availability, and been very actively partnering with the broader efforts in this to say that this, gives us the economy of scale, this gives us the efficiency. So in that effort, we've tried to enhance the awareness of STD screenings as part of the model that we're rolling out, as well as recognizing the factors and the roles of family and family involvement in all of these, having some screenings around what that family environment is, and as well as being able to provide some early intervention tools with that. And some of those efforts are funded through this, some of those efforts are funded through other sources we have, but putting out some training around those, screening and early intervention tools. Trying to utilize across all of our services evidence-based models, trying to implement a sense of trauma-informed care into all of the systems to better enhance our coordination and to be able to provide for us some of that data that we need to see how well is what we're doing, how well is it actually working. So again, beginning to lay out across our existing crisis teams and those that are coming online, in terms of having child specialized, resources, some standardized guidelines, some trainings, and some consistent data elements, both for the child space and then across the lifespan around these tools. Stephanie had mentioned this in the earlier slides, the idea of using the CAT as a standardized screening tool, adding some modules to that around substance use screening, trauma-informed issues, measuring our ACEs, and then the CANS as being a tool to assess how progress is happening for the child in those programs. And these are tools that are fairly familiar to most of our providers at this point. It's just having some consistency of their being utilized across the state. And perhaps as things evolve and we get more information, we may tweak and modify that. But those are our sort of starting parts at this point. Next slide. So laying out what are the pieces of a high quality, contemporary children's crisis system. So really customizing the care for children, youth, and young adults to meet their unique needs, being developmentally mindful of where children and youth are, being aware of the role of family. Another unique piece is that the crisis is defined by the parent or the caregiver or young adult. This allows for, in some ways, a more tailored and an earlier intervention. If something is a crisis for a family, having the resources to come in and start addressing that there prevents it from getting to a level that it may become a crisis in the bigger sense that requires, this person is going to be looking at an emergency room. This person is going to be looking at it being pulled and placed out of home. But being able to do that intervention a little bit earlier in the array can help reduce the situation, de-escalate the situation, but it's also demonstrated as being cost savings over time in a couple of states that have really started to pivot towards this type of an approach. Our law enforcement and our role with law enforcement is a little bit different, but the reason for this is I always put in humor, police officers, handcuffs, and kids don't mix well, because the image isn't good. So our law enforcement agencies can be part of the system, can be helping to refer families, but prefer not to have them responding with the mobile teams, again, for the obvious reasons of just, the image of this. The availability of these kind of services 24/7, the availability of these services having cultural and linguistic competence. Again, pieces that, we bring to the table and are needed in terms of a child and adolescent space, but absolutely are resources that are applicable and relevant across the whole lifespan, and different other, subpopulations that need more specialized care. Next slide. Okay. So I wanted to talk about just the design and intent of what is a child model. Specifically, as I mentioned, design to meet the needs of children, youth, and young adults and their parent caregivers. The goal of these services is to de-escalate and ameliorate a crisis before the need for more restrictive and more costly interventions. Diversions from ER, diversions from hospitals, diversions from RT residential treatment centers, and most important, diversion from out-of-home placement, for our youth. And to being able to ensure a very timely connection to the necessary services in the moment, and then those supports and services that we can connect them to as a next step. The key principle of all of this is the real shift from the overuse of high-end services to the use of home and community-based services. And this is a culture shift, because traditionally therapists have put on their voicemails, in the case of an emergency, call 911 or go to your nearest emergency room, and we really need to help facilitate a shift away from that across the whole array of services. The next slide. So referencing back to what are we looking at as a child crisis model, it's that triage point, that place of earliest, identification and intervention. That may be the call in to a regional call center. That may be the contact with a mobile team. That may be somebody, where they are working into an emergency room. It may be where they're reaching out in terms of the school system. But having some consistent engagement and some consistent triage to assess what the best next need is, perhaps using consultation, as was mentioned, we're building up some networks in terms of specialized pediatric consultation services to be available, where it's harder to obtain that kind of specialized service. Then going to an acute intervention and stabilization, and really training our existing teams and resources in terms of what does that entail. What is it that teams can do? What can they teach families to do to help de-escalate a situation? And there's some very specific crisis type work that is out there in terms of evidence-based practice models. CPI being one, Crisis Prevention Institute being one that we're really looking at. We're looking at for not only BHA, but DHS is looking at it as well. Some of our residential programs use this as a model to help, de-escalate a situation. And then once somebody's stabilized, being able to make those next step referrals. Not every crisis needs a referral to therapy. So maybe it's a referral to case management to help with some of the psychosocial needs. Maybe it's a child that really has a lot of needs and needs a referral to the local care teams or our target case management 3 or high level interventions to be able to connect to the right appropriate services. So next slide. Talk through some of this, the pieces that are in triage, the call centers, the screenings, training our tools on quality interventions. Mention again the resources available in terms of the consultation piece. Go on to the next slide. Stabilization, again, giving evidence to be able to inform the situations, particularly the CPI model we're looking at. Providing family with the tools to manage future crisis, that's a key component and important feature. If families buy into the plan, if they're agreeable, if they feel like they can actually do what's being asked of them, you're going to have a much better outcome than if somebody is authoritatively telling somebody what to do and they don't feel a part of the engagement. And we're looking at using the CANs as a tool to assess, progress over a longer period. Next slide. Going in, referrals, not everything needs a higher level intervention, but the importance of a warm handoff, meeting to make sure that connection is still there until a child and family are well integrated into the next step. Some other options in terms of what that next step can be. Go on to the next slide. So another similar description of what this is that's out there in terms of national best practices, is out there in terms of where some of the other agencies are looking, is mobile response stabilization services. And that really is the same type of a principle. It's a principle of wraparound that, pre-existed us in this state, has been around for, a decade or so, and it's taken a little need to sort of reboot and get us back on track with this. but it's a crisis and stabilization service. Talks again about the fact families in a crisis can get immediate response, having a local team coming out to de-escalate, the timeline of how long that team is engaged. We're looking at sort of a short-term acute intervention, and then the need for a longer period of time. For our Medicaid families, we can refer them over to the targeted case management group, and that can help the engagement. For our non-Medicaid families, we may be providing a little bit more service to help make that transition and actually make sure there's a good warm handoff. And then just the principle of a crisis being defined by the family and having that first intervention where at all possible take place in the home and community, as opposed to needing to raise up to a higher level of care. Next slide. Okay. So again, I'll stay on for questions later, but happy to sort of pass the baton over to Kathy Rebbert-Franklin to talk about, you know, what is that hotline, that entry point, and the updated 9 to 988.
Okay, thank you, Maria, and thank you to Kate and your staff for having me here. I appreciate being part of the panel to talk today. I wanted to give an overview of the National Suicide Prevention Lifeline. It operates as a 1-800 number currently. It routes calls to all 50 states. It's been in existence since 2005. It's not a new number. It's been around for a long time. And it's been operated by SAMHSA and their contractor, Vibrant. So you're going to hear me say Vibrant through this presentation because they own the contract for this service. In 2020, Congress passed a law to transition the current 1-800 number to a 3-digit number, which is 988. This number is different from the state's 211 press 1 that was also predated by a 1-800 number. 211 press 1 has been in existence for several years, and it serves crisis information and referral needs for those with mental health or substance use concerns. Next slide. So starting in 2017, there was significant advocacy that took place to push the idea of an easy to remember number. By August of 2018, legislation called the National Suicide Hotline Improvement Act was enacted to direct the FCC and other agencies to study this issue. And in 2019, the FCC recommended implementation of 988 to Congress. Next slide. By the following year, in 2020, the National Suicide Hotline Designation Act was signed into law, and this requires a transition to 988 by July 16, 2022. The 1-800 number will still be in operation, and the routing of 988 calls will use the same platform that's being used now. Either number will work to get a caller to a call specialist. 988 is not a new line, it's just a new number for the same purpose. But with the new number comes an anticipated increase in volume for calls, chats, and texts, as well as increased standards for answer rates and other potential requirements. Also, as part of this legislation, the FCC is currently studying the feasibility of providing geolocation and dispatchable information. Currently, calls are routed based on the first 6 digits of the caller's phone number, which could be problematic. Geolocation information for 988 calls would enable callers to be routed to the crisis call center closest to their physical location. Next slide. Here we highlight the benefits that Lifeline hopes to achieve by the transition to 988. The thought is that 988 is parallel to 911 and that it provides an immediate response to a mental health crisis. And this is intended to reduce stigma for those seeking mental health care. The goals are to intervene at the time of need using mental health resources, thereby reducing the need to use law enforcement and other healthcare resources. And Vibrant anticipates that there will be significant increases in the number of calls, texts, and chats due to the transition to 988. Estimates identify a doubling of calls, chats, and texts in 2023 and a potential tripling in 2024. Next slide. So Maryland has been part of the National Lifeline since its inception. There are 8 centers in Maryland that collectively cover all areas of the state. Vibrant directly contracts with these call centers and controls the routing of the calls. 6 call centers are primary, 2 are backup. They average a total of approximately 3,500 calls per month. And 3 of the 8 also provide chat and text services. And all of those services are provided 24/7 by these call centers. In 2021, there were approximately 43,000 contacts through the course of the year. Next slide. Vibrant requires specific standards in order to be designated as a Lifeline center. And these include accreditation, certain policies and procedures. There have to be quality and data requirements that are met, and there are other considerations such as agreeing to meet the 80% answer rate. Next slide. So in order to prepare states for the upcoming transition to 988 and the increased call, chat, and text volume, Vibrant provided funding to states to create an implementation plan. BHA created a work group comprised of representatives from the call centers, advocacy groups, including NAMI, and other stakeholders. This group met monthly starting in March of 2021. It became quickly clear that the lack of funding supporting the current 1-800 Lifeline number is a significant problem, and the anticipated increased volume will exacerbate that problem. This group will continue to meet through the fall and into 2022. Next slide. So we submitted a draft implementation plan with 3 focus areas, and the first being funding. Despite having a contract with Vibrant, Lifeline call centers receive minimal federal funding for the 988 services, and the Lifeline has been operating outside of the state's call system, so no funding has been provided through the state. However, with the transition of some of the responsibilities of 988 to the state, we are identifying sources of funding that's essential to ensure that our Lifeline centers have capacity to meet the projected increases in volume. So for capacity, the Lifeline centers provide high quality, statewide 24/7 call coverage at or above the 80% in-state answer rate that will be expected by Vibrant as of July 2022. We're already meeting that. Lifeline centers in Maryland also provide 24/7 chat and text coverage. However, with the increased volume, Maryland centers will be challenged to maintain their current answer rate and to meet Vibrant's future 90% in-state answer rate target, and to do it with quality in mind. And finally, regarding coordination, Maryland has an extensive crisis response continuum, as Stephanie was referring to and Maria was mentioning. We have an existing and well-marketed 211 Press 1 crisis hotline and a number of ongoing crisis service improvement initiatives. The state will need to coordinate closely with multiple stakeholders to ensure a shared understanding of 988 and its relationship to existing Maryland crisis services and initiatives, along with clear and consistent messaging to Maryland residents about available crisis resources. Next slide. So what's to come? MDH is looking at areas of consideration for the short and long term. For example, we're determining how 988 will integrate with our existing crisis call system 211 Press 1. 988 routes calls based on the first 6 digits of the phone number, as I mentioned, which means where you buy your phone determines where your call is routed. They're working on this. The FCC is actively working on it, but routing is a current problem that they are trying to solve. 988 is also branded as a suicide prevention and mental health crisis line. For comparison, 211 routes calls based on the location of the caller. It uses cell tower technology, and 211 Press 1 provides crisis information and referral for all behavioral health conditions. Other integration discussions center around local crisis call system efforts, such as the GBRICS regional model. The anticipated increased call, chat, and text volume raised concerns about quality of service and ability to manage a large increase. BHA has dedicated American Rescue Plan Act funding to 988 call centers to support current and new volume, and will continue to remain diligent about locating additional funding. And finally, MDH is considering what improvements should be made to the entire crisis call system to enhance customer service. And to this end, the Maryland Department of Health Secretary Dennis Schrader has elevated this work by assigning Tara Hargadon, Assistant Secretary for Customer Experience, to oversee 211 Press 1 and 988. The responsibilities for our crisis call system are now shared between BHA and Tara's office to capitalize on department resources, and more on that will be forthcoming. Next slide. So thank you for your time. We appreciate being a part of your 2-day conference, and we are open to questions.
Thank you all so much. That was a great presentation. I think right at the top, Stephanie slowly called BHA's approach to crisis response transformational, and from a NAMI perspective, it certainly is. And the enormous steps that you all and your agency are taking to address, children and youth in crisis, and putting a greater focus on walk-in stabilization centers are, some really exciting developments. And of course, we've been following along and participating in the 988 planning process, and really look forward to when that goes live, and then sort of the subsequent strengthening and, expansion of our crisis service system here in Maryland. So with that, we've got a couple of questions coming in. The first one was from Jocelyn. Is there any data broken down for ED visits by ethnicity? And I think this came in when we were talking about some of the suicide prevention efforts. We would like to see a greater number for minorities nationwide. A CDC survey confirms higher reports of depression and anxiety, especially among Latinos. So are we tracking it all, ED or crisis admissions by ethnicity, and sort of where are we on that?
I believe that we certainly are looking at that. I know that Dr. Jones is working with our suicide prevention team to make that happen. It might be a benefit if we ever wanted to just have Dr. Jones and that team come back and speak specifically to that. I think that would be a good question. I don't have the data on hand. Maybe I don't think Kathy nor Dr. Stanco does, so I don't want to misspeak, but that is an area of focus for us. It is a drive for all of us, and making sure that, in order for us to have that information, data collection has to be stronger and has to be diverse on its onset. And that's where our focus has really been, making sure we have asking the right questions to tell the correct and accurate and overall data story. But Kathy, you might have something you want to add.
Yeah, sure. So we are creating a data dashboard for suicide prevention, and we are breaking it down into a variety of categories, including ethnicity and race. And so we are able to then target actions, which is really critical in our field. We need to target where we are putting our prevention work, as well as our access to service work. And that data dashboard is in the final stages of completion. It will then be shared with our local partners to then use that data to make actionable decisions in partnership with all of their stakeholders. So we completely agree, Jocelyn, that the data is critical in understanding where we are and where we need to focus.
Thank you, guys. That's a really helpful update. The next question is from Donna, and she asks, do you see a role for peer support, like a NAMI affiliate, to help in a crisis center?
Yes, absolutely. And in fact, we have been having active discussions about this particular issue. We recently put out a NOFA, a Notice of Funding Availability, for peers in OTPs, and are on the cusp, as in the next couple of days, ready to put out a NOFA to put peers into crisis walk-in centers. And so we are actively pursuing that. We think that peers have a viable role in all of these settings. At any point of intervention, we think peers need to be involved in these settings. And we're talking about both mental health and substance use peers. And so peers play an active and vibrant role in our settings, and they are a core source of support within these service settings. So yeah, we're ready to put it out. She must have read our minds.
Yeah, and if I could just piggyback off of what Kathy and her team is doing, is I think phenomenal. But we in the crisis work group feel that peers are really going to be the transformative linchpin to that. A lot of times people are having lived experience and need someone to kind of help usher them through or help talk them through. And we've seen the effectiveness in peer recovery. We've seen the effectiveness on the somatic side with why can't the community health workers? And so we really feel that is the piece that will really enhance the work that we're doing. And so we really want to continue to support those efforts. And Kathy and her team have been phenomenal. I'm really excited about this NOFA that's going out, and I really do hope that those that are really interested in being a part of this space and trying to move the needle forward and really establishing why we need to have peers in all spaces, but currently in crisis space, I think will be really helpful.
All right, we're getting a few more questions and we've got a little bit of time. So if you guys don't mind staying on, we've got some really good ones coming in. So Alita asks, this is awesome. Once 988 is up and running, what happens if the situation requires law enforcement intervention? Will those police officers, law enforcement officers, be trained to help without hurting and arresting persons in crisis?
Yeah, so, obviously the goal is to not involve law enforcement, and that's always been, the push. What will happen in the future is what's happening now. And so as we continue our efforts to manage a situation without law enforcement, that will continue into the future. 988 isn't new. It's just a continuation using a different number. So instead of someone calling 1-800, they'll just call 988. It's really an attempt to reduce the stigma of different than. It is along the continuum of a health service. It happens to be a mental health service rather than a medical health care service like 911 is. But it's always our goal, as Maria was speaking so eloquently to, it's always our goal to avoid the involvement of law enforcement and other healthcare resources. We don't want to take people to an emergency department unless absolutely necessary. And so, that's what this build out is all about, in addition to serving the greater good, serving people who need it in a holistic kind of way. It's about avoiding unnecessary use of other resources that don't deal appropriately with people that need services. And so we really want to make sure that we put the right kinds of services with the people that need them at the moment.
Yeah, couldn't agree more and believe that 988 will be instrumental in that. And at NAMI, we like to say a mental health crisis deserves a mental health response. And so, we're really appreciative of the focus you all are putting on that. Very similar question around the same lines, but I'm going to skip to the second half of Becca's question, which is, are you going to be partnering with hospitals and or psych wards? So I presume like inpatient admissions, so that they are better equipped in handling consumers who are being brought in and stemming from crisis response cases.
Stephanie, I would say that that's part of the bigger crisis work that has to happen.
It is. I would agree. I think that is the work that we want to do. And I think, we are, whether we're looking at HB 1121, which is the referral and crisis services, we have already started an alignment with the Maryland Hospital Association. We already have strong partnerships with our private hospitals and really working comprehensively to look at that. And even in the slides that we talked about, that provider education piece is going to be critical as we try to socialize what does it look like for individuals in crisis, not just in a crisis state from a clinical perspective, but a crisis state from a cultural and ethnic perspective, and recognizing that that's going to look different to everyone. And so I think that is the goal, and that is why we're partnering. I think we all statewide are very concerned about the amount of individuals that are utilizing the ED as a way to go for crisis. And I think Dr. Stanco said that too. A lot of providers will say, if you're in an emergency, please go to call 911 or go to the emergency room. But if the emergency room is not responsive then, or not aware or prepared, then it still perpetuates the crisis that someone may be already in, or exacerbates it in a sense. So all of that is still the work that we are really working on, and really trying to partner with everyone at the ground level so that we all are driving. And I think that that's the point. And I want to make sure I emphasize is that the whole thing is that a lot of people have to take up and work in the crisis space. NAMI, the health department, everyone has to be a part of it. But I think it's important for us as the Behavioral Health Administration to say, if you are going to be rendering any services that can be anywhere associated with crisis, this is the best way to do that. And we're utilizing evidence-based practices and then expounding on that with our subject matter experts to really say, now when you render services, we are expecting that this is the model and this is the pathway in which you go. And I think that partnership with those hospitals is going to be key and critical, not only for them to be a part of the system, but be responsive when those events and incidents occur.
Thank you. Little bit of a hot seat here, but I'm sure everyone in the audience will support it. Any chance the state will be looking at increasing the salary for peers? They are invaluable. And this is from Anne.
So I can tell you that we understand and agree, and we have limited control over what independent entities pay peers. However, for state salaries, we are having internal discussions about the peer salary scale. It's not just the salary, but it's a career ladder that's needed. And so our discussions include what is the salary that should be paid, is the MS-22, I'm now doing state speak, is the job description adequate? Does it adequately represent? Because it's now about 5 years old in the state system. And so, we're revisiting all of that. And then how can we create a career ladder so that individuals stay within the peer workforce for a longer period of time? Because unless you are paying a livable wage and you give someone opportunities for advancement, they're not going to stay. So this is absolutely, it's an active discussion where we have appointments set up as we speak. So we're on it.
That's great. And, I think all belief peers are going to be that bridge in terms of some of the workforce development gap. And then so figuring out what do we do to help them get the additional certifications if they need and, are interested in. But
Right. And so to that end, I can plug one of the things that we have done, which is we've worked with MAB PCB, and that's the board that certifies peers. And we have provided funding so that they can provide new certifications or renew certifications for free. And so people still have to get their CEUs, but they can renew their certification for free using the funds that we've given them as one attempt to try and make it a little bit easier for individuals to become certified or recertified.
Awesome. What else do we have? Maybe a couple more questions. Catherine asks, how can we transition from law enforcement to crisis teams in responding to behavioral health crisis? And before I turn it back over to the BHA folks, I will just tease, we've got an advocacy session tomorrow that's going to talk a little bit more about some of NAMI's policy and advocacy work in this realm, but it's a systemic change. And I would say a partnered law enforcement response maybe works well in some jurisdictions, and in others, I think it's time to figure out how we can reduce that and again, make sure we're providing that mental health response. And it's gonna take, I think, years and investment from state and local governments to make that transition work. But we're on it from I think a public policy perspective, and curious, I think you guys covered a little bit of that, but if Kathleen or Stephanie, you have anything additional to add on that front?
I think what you said was accurate and appropriate. The only other thing I would probably add to that is it has to be a mind shift. I think that we have overly depended on 911 for everything, and we need to recognize that 911 can't be everything, just like a grocery store can't be everything, and we need to utilize it to its strengths. If we utilize 911 to its strengths, it is an invaluable resource. But if we make one system the system for everything, then it has no point but to fail. So we have to shift our mind, not only that there's more than one path to address emergency, there's more than one type of emergency, and we need to be more broad in how we address and meet that emergency. And I think that also comes with a mind shift, not just a number change, but we all have to shift our mindsets to really recognize that we did that before when we used to look at substance use as a criminal act, and now we look at it as a disease process. So we can do it again when we're looking at how we address crisis in our communities for those who are suffering with mental health or SUD crisis.
I think we've got a handful of questions kind of along the same line. And so I want to maybe just for a moment acknowledge there are a lot of NAMI grassroots consumers and family members or caregivers who've gone through the crisis system and just experienced the trauma that comes with maybe being in ED setting or becoming justice involved when really you're having a mental health problem. And so, I think Kathleen and Stephanie and Dr. Rodowski-Stanco, you all had sort of covered a big part of this needs to be additional training, not just for law enforcement and not just for emergency responders, but also those physicians, and there are some ongoing programs, but I think it's just clear from kind of the tenor of the questions that there's more to do, so that kids and adults aren't internalizing that trauma and stigma. But, you know, we've got so many stories here at NAMI about people going through that. So I think I want to acknowledge that, because again, we're talking about transformation and systems change, and I think we are all feeling so encouraged by the infusion of federal dollars, and I think also the state making this more of a priority. So one technical question that I think is really important to address on 988 is the connection between 911 and 988 and 211, and how's that looking on the implementation side of things. And then I think we'll be sort of at time and wrap up, but that's one of those questions that we get when we talk about it as NAMI, but where is that, I think, from like your all's perspective on how will that integration go?
So the 988 and 211 Press One, it is acknowledged at the state that we need to move towards an integration. We are not there yet, and how we do that and what it looks like, it has not been decided yet. So MDH is in this discussion, and we are actively talking about pros and cons, different approaches, how we want to do this. It is a major system change within the state. 988 has always been the responsibility of the federal government, and has been an arrangement between the federal government and our local call centers. The local call centers participating in 988 also participate in 211 Press One. So we're fortunate in that way. They're all the same, call centers, all the same people. But the way that we manage this is not yet clear. It's not yet answered. So I can't give you an answer. And then layer on top of this are, as I mentioned, some local efforts that are going on. And so we have GBRICS, who is doing a regional pilot model. And how will that work out? And how does that then interface with 211 that has different regions, and 988 has its own regional setup? So, there are some complications and layers of complexity here that we have to work through, and we don't yet have the answers. I know that there are discussions at the federal level about 911 and its interplay with 988. There's a commitment at the federal level to make it so that 911 has its own space, and its space does not interfere with the 988 space. And to speak to what Stephanie was saying earlier, we do not want to criminalize behavior. And that's what has happened, and we want to stop it, and we want to actually put in the appropriate response so that people get the care they need. I think we've all been touched by instances where people are trying to access the system, and the system is difficult, it's complicated. And even people who know the system have trouble accessing the system and getting the resources that we need for people that we care about. So we acknowledge that. All of this is an effort to try and create a systemic solution to a systemic problem, rather than trying to put Band-Aids and create little projects here and there. We mentioned a lot of little projects, which are super important, but at the same time, if you don't have the glue kind of holding it all together, which is what Stephanie was presenting on and Maria was presenting on, we've got the glue now in place to hold it all together, and we're trying to put the pieces in place to make sure it happens successfully.
Well, thank you so much. And again, I think we're at time. We're really, really grateful you guys carved so much time out on a Friday afternoon to be with us and to present as our afternoon plenary today. And I think reminder to folks about the survey following this, if you're seeking CEUs. The next workshop session is going to begin at 2:20. Be sure to check out NamiLand and some of the other virtual resources in the virtual exhibitor hall. Participate in the resource scavenger hunt. If you find the resource listed, you might be able to win a DSW messenger bag. And again, thank you very much to the Behavioral Health Administration and for everyone in attendance. And we hope you enjoy the rest of your conference.
Thank you very much.